Moving on to the next topic, current concepts in labor analgesia by Bhavanishankar, Kodali. I request the chairpersons to introduce Dr. Bhavanishankar, Kodali.
Good morning, everybody. Dr. Bhavanishankar Kodali is an MBBS, MD, and FASA. He is the Chief of Obstetric Anesthesiology at the University of Maryland Medical Center, Chief Safety Officer, Department of Anesthesiology. He is Assistant Director, Maryland Anesthesia Simulation Training and Research Center, Professor of Anesthesiology, University of Maryland School of Medicine, and is the author of www.capnography.com and www.painfreebirthing.com. A very impressive CV. Over to you, sir.
Thank you very much. And actually, I have to thank Dr. Usha for personally inviting me for this meeting. And it is a pleasure to be here. Now, today, actually, I'm going to talk about some salient features of what is the current status of labor analgesia. Now, I do maintain a website on the painfreebirthing.com, which is a patient-oriented website and gives a complete idea about what can be offered to them to decrease the childbirth pain. This is translated into about 8-9 international languages, and of course, Google has multiple translations for that. Now, some of the questions that arises is when to place an epidural. So this is no more a controversy. Epidurals can be placed at the request of the patient as long as the labor is established. Now, although we all know that labor analgesia, particularly the neuroaxial analgesia, prolongs the first stage of labor by 1 hour and second stage by 10 minutes. It doesn't really matter as long as the patient is comfortable. However, the instrument delivery is actually increased following neuroaxial analgesia. Now, this is true for the Robson's classification. Robson's classification is 10 groups, depending upon the gestational age, depending upon the position of the fetus, multiparous, nulliparous. In all these 10 groups, the neuroaxial analgesia is associated with an increased instrumental delivery, such as forceps or vacuum. Now, what are the current labor analgesia methods? We have the neuroaxial, the intravenous, and also inhalational. Now, what is the current status now? The epidural labor analgesia combined spinal epidural, dural puncture epidural, continuous spinal, and single shot spinal are the modalities of neuroaxial analgesia. Now, within the epidural, the programmed intermittent epidural bolus is probably more common now, at least in most of the Western countries, followed by the patient control epidural analgesia, then of course continuous epidural analgesia, then there is what is called as a manual intermittent epidural analgesia or manual intermittent epidural boluses when you don't have access to the pumps. Actually, I put this MIEB in the plane today, actually. Suddenly I got this idea, so I just added up in the plane. Now, going about 24 years ago, we did a small experiment. At that time, the continuous labor epidural was very common. So we put on a filter paper the spread of the medication at 10 ml per hour. The same thing we divided into 3 aliquots of 3.3 ml every 20 minutes. And the spread on the filter paper was remarkably high compared to the continuous method. So I did a study at the time, which I called it as epidural fountain, and presented at the SOAP, where we showed that giving the drug in the boluses was very, very efficacious. This was followed by multiple studies by many authors, including Cynthia Wong, and that actually culminated into this programmed intermittent epidural bolus mode. Now, when you look at the PCA and the PIEB, they are much more superior compared to the continuous because it produces a very superior and improved analgesia. Your interventions are actually decreased. and you use less local anesthetics, and actually the patient feels better because she thinks that she is actually controlling her labor pains. And that has got a lot of psychological bearing. The common drugs that are used now are the concentrations are bupivacaine, of course, which is 0.0625% to 0.125%. Some clinicians, they bolus the patient ahead and then start the infusion. Some, they just start the PIEB. So it depends upon the practice. Now, I did give what are the probable doses that are used. If you are using PCA, it is 6 ml continuous and 6 ml Q 15 minutes patient control. In PIEB mode, the difference is there is no continuous. It is 9 ml Q 45 minutes the pump gives, and the patient has the option. Now, the real dosage and the lockout time depends upon your patient population. Instead of using 10 ml, you can use 5 ml Q15. That's what some institutions do. So that depends upon the requirement of the local population. Now, when you get an accidental dural puncture, actually you can put a continuous spinal catheter. However, the continuous spinal catheters are associated with prolonged second stage. It is 27% versus 19%. And of course, those are the medications that are used. You can use the same mix, which is 0.0625% at 2 ml per hour, or if you are using 0.125%, then you use 1 ml per hour. Now, another thing is, when you use these continuous catheters, one problem is they do not work very well for cesarean section. This is very strange. You think it is in the spinal. Why is it not working? The reason is the drug tends to settle at the lower part of the spinal cord or the CSF, and you do not get good spread. So when we did the study based on observation, what we found was the failure rate was almost 14%. So because of this, if I get an accidental dural puncture, I tend to put a fresh epidural rather than using a continuous spinal, unless the patient is morbidly obese or it was a difficult epidural. What about epidural, dural puncture technique? So here what you do basically is you locate the epidural space, put a spinal needle, make a small hole but do not give any drug, and then you just put the epidural and then load up the epidural space. The drug probably migrates through that small hole. Originally, when this was done when I was at the Brigham and Women's Hospital. Initially, we thought that we had a very good sacral coverage, and also it produces a little bit of a faster onset of action. However, subsequent studies are a little bit of a controversial, and in the just about last year or in the beginning of this year, a paper published in Anesthesiology about the dural puncture technique in morbidly obese patients did not make any difference in the outcome. So, but one point you have to be careful is you should not poke the dura without knowing where you are, because you know that at 25% of the patients the spinal cord comes at the lower border of L2, so you may injure the chordae vena. So therefore you have to be careful. So personally, I am back to epidurals now. I put straight away epidurals. In my opinion, if you are a good epiduralist, your epidurals will work well. Now, of course, this was one of the papers, again, a dural puncture technique on the PIB, which was published in Anesthesia Analgesia, and I wrote a letter to the editor saying that the methodology used in this study was not perfect, and therefore we cannot justify the results. Then, nowadays, you are getting a little bit of flexi catheters, what we call as aeroflexi catheters. We know that aeroflexi catheters are less traumatic, less vascular incidence, and also they do not produce that much of irritation when you thread the catheter. But one of the things is they are difficult to insert, and that was highlighted by some of my former colleagues. Actually, I published one paper in the Indian Journal of Anesthesia about the various types of the needles. You know that every epidural needle that is produced by various companies is not same. So when you get used to one needle and suddenly you change to another needle, your tactile perception of the needle changes, and there is a possibility that you can get accidental dural puncture. Now, anyone who practices epidural for labor in your institution, particularly when you have got residency programs, you must have something like this: how to troubleshoot not adequately providing epidural catheters. This is very, very important, very, very easy. You just have to give clinician boluses, or you have to give 1/4% bupivacaine boluses, or if it is one-sided, turn the patient to the other side and see if because gravity does affect, or you have to pull the catheter, that you can try, but don't waste too much of time. If within 45 minutes or so, if the patient is not comfortable, it is better to put a new catheter, because we do not know when a C-section will be called. And the Society of Obstetric Anesthesia is what is called as the Center of Excellence. They give you the certificate, and one of the criteria there is the failure to convert the regional anesthesia to a successful regional anesthesia for cesarean section should be less than 2%. Then the Society of Obstetric Anesthesia and Perinatology comes up with some of the bulletins which are very good. You must read them. And this is on the platelets. About platelets is about, you can do neuroaxial anesthesia if the platelets are above 70,000. But there is one caveat which you must always remember, that all other coagulation functions must be absolutely normal. You cannot compromise on any other coagulation functions. If you just isolated platelets, then probably 70,000 is pretty good. Now, one simple message I want all of you to take home. We are all dependent on sophisticated coagulation methods like thromboelastography, ROTAM. Although we have both of them with us, I still use this technique. I take blood whenever there is a hemorrhage, or even when I don't have labs before doing an epidural. I take blood in a red top, leave it for 9 minutes. If it clots, that means the patient does not have any significant coagulopathy. This is very, very useful when you are facing an obstetric hemorrhage, because right away you know whether this patient has already gone into coagulopathy or the patient's coagulation is fine, and whatever the bleeding that is happening is purely surgical. Then, of course, this particular test was actually validated in India by a group, and what they found is actually a fibrinogen of less than, say, 150, the time, the red tube clotting time goes beyond 11 or 12 minutes. And I use actually about 10 minutes, which is probably okay. Now, gastric emptying during labor has been studied, and a paper recently published in anesthesiology, they gave some yogurt and looked at the ultrasound examination, and they did find that pregnant patients, the gastric time is delayed, but epidural did not affect the gastric emptying time, at least in this study. However, we wrote up an up-to-date, because we do myself and Dr. Michaela Farmer from Brigham, we write the up-to-date airway management. And in that we have written that the BMI of those patients is very less. It is 25 and 30. In our practice, at least in Maryland, a BMI of 55, 60, 70 is not that uncommon. So you cannot interpose those results. Now, this is another study that came up in India actually, and they looked at some of the groups, at various pregnant groups. They did the ultrasound examination. They found that if the pregnant woman is adequately NPO, so which is about 8 hours or so, that means the stomachs are generally empty in those patients. However, again, I point to the same thing. They're all low BMI patients, and you cannot apply this to a high BMI or a patient who has got diabetes, etc., or morbidly obese patients. Then, of course, this is not really applicable for neuroaxial anesthesia, but I thought I would just mention it, which is the use of norepinephrine, 2.5 micrograms per minute of infusion compared to 50 mics of phenylephrine to keep the blood pressure steady after spinal anesthesia. And norepinephrine did a better job, actually, or as good a job as phenylephrine. But there's nothing to change. We still use phenylephrine for our spinal cases to maintain the blood pressures. And we use phenylephrine infusions even in those patients during neuroaxial labor if there is a hypotension and the baby is not tolerating the blood pressures, we actually put them on baseline phenylephrine infusion. This particular paper very recently published in British Journal of Anesthesia, but I don't think we should worry about it. This is just tells you that phenylephrine has got some sort of an anti-inflammatory effect. But I think it is mostly laboratory now. I don't think we should worry about clinically in our practice. Nitrous oxide, it's still, we use it, and many centers use it. As long as the scavenging system is fine, it is pretty safe for the providers. But of course, there is a lot of environmental issues now. People think nitrous oxide is also an environmental hazard. Intravenous analgesia, I will just point out to three things: fentanyl, remifentanil, and dexmedetomidine. Fentanyl is still probably the most commonly used. Remifentanil, I gave the doses in the handout along with the dexmedetomidine. The problem with remifentanil is it produces the respiratory depression in the mother and also the fetal heart rate changes in the baby. And dexmedetomidine produces sedation in the mother and also produces bradycardia in the baby. So, remifentanil and dexmedetomidine never took off. In our cases, we are using fentanyl. Then what about single dose, intrathecal labor analgesia? A combination of fentanyl 25 mics, bupivacaine 2.5 milligrams, and morphine 250 micrograms probably gives you a good labor analgesia, at least according to some papers, going up to 4 to 5 hours. And there is no increase in cesarean section or the instrumental delivery. However, the side effects are motor weakness and also pruritus and nausea and vomiting. But this is a good alternative when you don't have an established neuroaxial labor analgesia service. Now, a way back, I wrote an article on establishing an obstetrical neuroaxial service at low resource areas, where actually I summarized how to go about if you are starting a unit and what are the requisites and what are the things where you can compromise and what are the things you should not compromise. You must have some sort of a pregnancy education guide if you are planning to establish a labor analgesia. And this is from the AOA. Now, you must also have a high-risk referral service because it has a lot of advantages, like beneficial, to get a team. Or, for example, if you have a patient with aortic stenosis, mitral stenosis, pregnant, teamwork is always better in those cases. Documentation is the key. I don't know, every meeting I tell them that whenever a labor analgesia is in progress, we have to document. And you have to also do a post-operative check. And last but not least is the teamwork. Never think that labor analgesia is just putting an epidural and then walking away. It involves a lot of things which you have to take care for the final successful unit. And it is a teamwork. You need a lot of people in the final analysis of making obstetric anesthesia safe wherever you practice. Thank you very much.